I'll tell everybody this when we get started. I'll wait. So we'll wait a couple minutes because I bet people are still logging in. I'm gonna check my email to see if anybody's having trouble. Hi, Katinka.
Hi, welcome. I'm eating my lunch, so I'm off video.
Understand.
So I have to ask what the weather is like, especially for those of you up in Wisconsin.
It's balmy today. It's 36 degrees, so we're all feeling like it's summer. We have our shorts on. It's pretty summer-like here.
Nice.
We would not have said that 2 days ago when it was like 6 degrees below zero.
Yeah, it's feeling pretty frigid here in Chapel Hill, North Carolina, but it's supposed to be 50 today, so
Uh-huh.
that's just relative temperature.
My parents are in Phoenix during the winters, and they'll call me and say, "Oh, it's chilly today." And I'm like, "What is it?" "Oh, 54." I'm like, "Okay, it's -6 here." So it is not considered chilly there.
Yep.
Hi, everybody. We're just going to wait for a couple more minutes. People are logging on here. It's our first meeting. I want everybody to get in. Only got 4 health systems on right now, so I want to wait for a couple more minutes if everybody doesn't mind. Go. There we go. I'm gonna log in. Good. Wait for about 1 more minute. Welcome, everybody.
There we go. There we go.
Oh, there's Marshfield. Good. All right. Okay, I'm going to give it until 1:02 and then we're going to kick off this meeting. I am recording, everybody. Welcome to the WCHQ Integrated Behavioral Health webinar training series with the Collaborative Family Healthcare Association and the Medical College of Wisconsin. Okay, I think we're going to open up and get started. Hi, everyone. I'm Jen Koberstein with WCHQ. Welcome. We're very excited to have all of you joining the first in a 12 webinar series on increasing integrated behavioral health in the healthcare systems that you work in. We're very excited to have you all here, and we're excited that you've all agreed to work on this project. I'm going to introduce just very briefly Katinka Hoyer. She is the principal investigator for the Medical College on this project. Many of you may not have met her yet, but you've seen her name on some documents. And I just wanted you to be able to put a face to a name. You want to say anything, Katinka?
Welcome, everyone.
All right. And I'm going to turn it right over to Naftali and Martha, who are our presenters each month. And they are going to take the lead in this meeting and every meeting, and just welcome everybody. And we'll do some introductions shortly. Glad to have you all here.
Yeah, well, it's a pleasure to be here with all of you. Thank you so much for taking time out of the middle of your day to work with us here. My name is Naftali Serrano, or Naftali Serrano, whichever way you are able to say it. I am the Chief Executive Officer here at the Collaborative Family Healthcare Association, where our mission is to support you. That's literally our mission. We exist to support healthcare professionals in integrating physical and behavioral health. And we want to make integrated care the standard of care nationally. We're a nonprofit, and yeah, we do everything we can to push this mission forward. And so we work with lots of groups like WCHQ nationally to in lots of supportive fashion. So We have a lot to share, but one of the things we'd like to set as sort of the ethos early on is that we're well versed. Martha and I are well versed in having a topic ready, having slides and all that, and then a group saying, wait, that's not really what's going to help us. Let's reconfigure this conversation. From today on forward, we want you to feel as if this is sort of an hour where you get some dedicated time to really think about how can we in 2022 really make a tangible difference in our health system and our clinic with regard to integrated care. So we're going to depend on you to nudge us. We have lots of experience with coaching people, doing consultation, doing the work ourselves clinically, but you're the ones that know what's going on in your health systems. And so we look forward to learning more about you and what the barriers are, what the challenges are, what the opportunities are that you face on a day in, day out basis. And if we need to toss a bunch of slides out the window, we're happy to do that for the sake of actually meeting the need that you present with. So that's a little bit about me. I want you to get to know my partner in crime here, Marta Saucedo, who is actually suffering along with you in Wisconsin. Martha, why don't you say hello?
Sure. So, hi everyone. My name is Marta Saucedo. I'm original from Mexico. So that's even crazier that I'm living in Wisconsin. I have a degree in psychology that I did back in Mexico. But then when I came here to the United States, I actually went into the route for social work. So I'm a licensed clinical social worker, and I'm the project manager for technical assistant here at CFHA, but had been in love in integrated behavioral health over 12 years. And I started my journey at, probably you guys, some of you will know, at Access Community Health Center. I started to be a behavioral health consultant there, and I continue to work clinically over there. So yeah, I have been very passionate about this model, but not just working in the model, but like Neftali was mentioning, kind of sharing our experience, but also kind of just the model in generally, so it can get expanded, not just in one site, but nationwide, and sharing with all of you what we have experienced through all the years that we have been working in this model, but also what we found other sites are struggling or they're having their challenges and how we can best support them. So I'm very excited to be with all of you here today. And because we already kind of introduced ourselves, we also want to know about each of you. So we would love to hear from which site you're coming from, what's the role that you play in your site, so we can get to know each of you. And I wonder if we should go just by the people that we see in the screen.
Yeah, and just to clarify, we're obviously not going to take time every time we meet to do this. We want to make sure we focus on the content as much as possible. But since this is our first time, we think it's really important for people to say hello and know where you're coming from. So yeah, we can just go down the list. And so in case if you're WCHQ staff and we're misrepresenting, just tell us that you're WCHQ staff. All right. So Alicia looks like, or Alicia, I don't know how you say your name. I said it in the Spanish way. See that? Alicia. So Alicia, or Alicia, can you tell us a little bit about what system you're from, what your role is? And then the other piece that Martha and I were really interested in is like what you're really hoping to get accomplished in 2022 vis-a-vis integrated care. Like what's like, if there's one thing that you feel like you would really like to get accomplished this year, what would that be?
Sure. So my name's Alicia, so it's neither of the options you chose, but good try. I work at Ford Healthcare in Fort Atkinson, Wisconsin, which is a small nonprofit hospital and clinics throughout the community. And I'm the behavioral health manager. Maybe this is too lofty of a hope, but my hope is to create a structure and framework and have all the information I need to be able to run with IBH into 2023. So that's me.
Awesome.
Welcome. Thank you.
Yeah. I think that's doable, at least, Alicia, to have that sense of a framework in place and guidance for that. I think that makes a lot of sense. All
I
right.
have Kara Winsand.
Hi, everyone. I'm Kara Winsand. I'm the Director of Practice Transformation at WCHQ. To be here.
Now you pick, Neftali. You have better luck than me.
Well, we're just going down the list. Erica Larson.
Hello, I'm Dr. Erica Larson, child and adolescent psychiatrist, and also the behavioral health service line medical director at Marshfield Clinic Health System. And our goal, I guess, is being part of this is to expand and improve our integrated care to service our patients the best that we can and learn from others and gather some information so that we can do that successfully.
Awesome. Awesome. Welcome.
Michelle. And I cannot see the last name. Rose. Michelle Rose.
Hi, I'm Michelle Rose Barajas, and I am a psychologist with Mercy Health System. I am the manager of Mercy's outpatient behavioral health clinics. So we have a lot of co-located behavioral health services in our medical clinics throughout Mercy Health, but we're really looking at trying to provide true integrated care, which I think is going to take, systemic buy-in from the upper level down through the physicians who are located in those clinics. And so I'm just excited to hear what other people have done to kind of launch this and get the buy-in that is needed to make it successful.
Right. Sandra.
Hi, I'm Sandy Bump. I am the Director of Behavioral Health for Marshfield Clinic Health System, as well as Operations Manager for Marshfield Campus and Clover Campus, and the Director for our Integrated Care Program. We actually have two different models of integrated care at Marshfield Clinic. We have two of our psychologists actually representing our PCBH model, and adult and child. And then we also have a care management type program that we have rolled out to 36 locations where we have nurses embedded in our primary care. We built this model back in 2014, and I think every opportunity is an opportunity to learn. And is there anything that we can do differently or evolve? So thank you for having us.
Great.
Awesome.
Stephanie.
Hello, I'm Stephanie Kolbeck. I'm one of the psychologists that is at Marshfield Clinic Health System with Sandy and Dr. Larson, and Dr. Diestelman is here too. He's my adult counterpart. I do all of the PEDS PCBH work, and also do specialty care along with that PCBH model. And for me, I agree with Sandy, always an opportunity to learn, and there's pieces of our practice that work really well and work very smoothly, and there's pieces that just, we could do better with, and that's what I'm looking forward to, is being able to enhance and expand the good work that we already do. So
Great. Thank you, Stephanie. Erin Fink. Erin, are you there? Okay, let's
Muted currently. Yeah, maybe move
yeah.
on to somebody else until she's ready.
Heather.
Hi, everybody. My name is Heather Pagel, and I'm from Theta Care. I'm the project director at Theta Care Behavioral Health, and my responsibility is really expanding and extending the behavioral health collaborative care model into our primary care clinics. And particularly, our focus most recently has been in our rural areas where resources are sparse or people need to travel. But just generally, looking at this group for ideas and support and kind of thought partnering on that.
Great. Jacob.
Yes. Hello. I'm the last person here from the Marshfield Clinic Healthcare System. There's four of us on the call today. Dr. Kolbeck referenced me. I am a psychologist who's embedded in one of our primary care clinics, and am here to try to make and help run the day-to-day functions of this PCBH model more effectively in a way that's useful, sustainable, and actually kind of gets to the core of what integrated care is supposed to look like. So hopefully I can learn a lot from everybody here. So thank you.
Pick up Jim.
Hi, I'm Jim Kubicek. I'm the service line VP for Ascension, Wisconsin for behavioral health. In Ascension, we've got lots of clinics throughout the state, and we're in a different place based on the region and based on the different clinics within the region, much like what other folks have said so far. So trying to look towards standardization and really kind of in a much more organized and comprehensive manner. How do we make integrated behavioral health a reality for in terms of what are the basics? What do we have to have in order to call ourselves an integrated system? And then what are the must-haves and what are the kind of the delighters, as it were, in terms of model development?
Great. Karen.
I am actually really the last person from Marshfield Clinic on the call. So I'm a clinical quality. No, that's fine. I'm a clinical quality nurse specialist. I'm relatively new to this role. Did some great work with Sandy and Jacob with a little bit more with chronic care. So excited to be in this new role and then to support their efforts on a bigger platform.
Great. Atinka.
Sorry there. My name is Katinka Hoyer. I'm a medical anthropologist and assistant professor in family medicine at the Medical College of Wisconsin. There's more divisions and stuff to add to that, but I won't bore you with it. And I'm the primary investigator of the grant. This is funded by the Advancing Healthier Wisconsin endowment. So welcome, everyone.
Thank you. And then I have Marsha.
Hi, can you hear me?
Yes.
Okay. So I'm from Reedsburg Area Medical Center, and we are a rural health clinic, and we're just, we don't have the integrated behavioral health in our clinic, so we're here to learn if this is something that we can, if it's something that would work for us, and something that we can, get going in our rural health clinic.
And then Erin again. I don't know if you're able to introduce yourself, if you're there. Okay, am I missing anyone?
I'm Dr. Mary Beth Shear. I'm also from Reedsburg. I'm one of the family practitioners and interested in hoping we can get into some behavioral health integrated in the clinic. We just have community partners right now. So hoping to learn from all of you in these different models.
Great.
Awesome. Well, thank you everyone for introducing yourselves and for giving us a little bit of a sense of where you are. As you can tell, and this happens in groups like this, there are folks at very different ends of the spectrum. Some of you have already been doing something for years. Some of you are just sort of in the conceptualization stage. My hope is that as we talk and have conversations, all groups can have the ability to learn from one another, ability to learn and interact with us as well. In addition to this setting, you all also have access to Martha and myself one-on-one for a certain number of sessions per site so that you can get some more individualized attention. So you can see this as 2 levels of interaction. Well, we have this time together, and then when you need to reach out to us individually to do some specific troubleshooting, you also have that opportunity. That said, like I said before, if you've got some stuff that you want to kind of discuss that's triggered by maybe something we start talking about, put it in the chat. We're happy to discuss. Yeah. So I should give you a little bit of background about myself as well. Martha gave you her clinical background. I am a psychologist as well. One of the rare psychologists that can say I've spent my entire 21-year career in primary care. Most of those years were at FQHCs, building integrated care programs. The last about 5 years, I've been at the University of North Carolina, Chapel Hill, in their Department of Family Medicine, where I do a little bit of clinical work, just because I love clinical work and I love, staying fresh with integrated care. It helps me in my real job here at CFHA. So that's just a little bit of background. We're going to take as much of a pragmatic stance as possible so that, again, you walk away with things. However, this first time, we found it really important to do level setting around like just language and constructs. And so that's what we're going to talk about today, because what we've found is that when people talk about integrated care or integrated behavioral health care or primary care behavioral health or collaborative care, a lot of times the words get really messy. And what one person means by one thing is not the same thing as someone else. So as we talk, we're going to encourage you to be very specific in your language in describing what your programs actually are, so that we can have an intelligible conversation about what our goals actually are. So I'm going to pull up a set of slides. My hope is that as I pull up slides, your brains don't go dead. I don't know about you, but sometimes in webinars, the slide comes up and I'm like, I start falling asleep right away. So if you need to stay awake, just like put something in the chat. All right.
Yeah, we're gonna be monitoring the chat. So anything that comes to your mind, please feel free to do so.
Yes, absolutely. Let's see if this, all right, Martha, can you confirm that it's showing up nice?
It's showing nice and clear. Yes.
Yeah, okay. All right. All right, so we're gonna really go with basics and just get the right language down. And I like to use this image to get us started. We call it the integrated care tree of models and clinical pathways rooted in perspectives. Just to show you that all of this that we're going to talk about didn't come out of nowhere. It actually came out of decades of efforts to make improvements in healthcare, and in particularly in improvements in treating people as whole people. So if you look down at the very bottom at the roots, you'll see a lot of language that probably many of you know, right? I mean, you've heard of population health, and you've heard of the chronic disease model. You've heard of PCMH and ACEs and trauma-informed care. All of that and more, actually, there's many other perspectives that are not here. All of that infuses what we're going to be talking about with integrated care. And in fact, the models that come out of this are in some ways products of all of these movements in healthcare to rectify some of the disparities that we know exist, rectify some of the system inefficiencies that we know exist, et cetera. So for example, when we talk about the models up at the top of the tree, you'll probably know if you have PCMH certification, you're probably going to be like, oh yeah, there's some elements there that align with PCMH certification activities. And that's because, yeah, that's part of what's infused the development of these models. Now, lots of times we like to use that word models for things that we like to call clinical pathways. So if you move your way up the tree to the tree trunk, we call clinical pathways processes that clinics embed into their existing processes to focus in on a particular area, right? So for example, 2 examples of clinical pathways. You all at your clinics have tons of clinical pathways for health and mental health issues likely. But 2 with respect to integrated care are things like SBIRT and MAT, right? So MAT is a more recent phenomenon than SBIRT, last 15 years or so, probably, and a lot of activity in the last 5 years, right? And so the idea of a clinical pathway is something that it doesn't necessarily transform everything you're doing in your whole clinic, but it is a set of processes and pathways that have to be sustained and maintained, but they're embedded in your clinic and they become part of your clinical practice, right? So MAT doesn't mean you become, for example, a substance abuse treatment center, right? You don't change your entire thing. You're just really embedding a process so that you have access to physicians that are prescribing Suboxone and some screening pathways and some maintenance pathways to make that work. Same thing with Espert. Now, when we get up to the model level, that's when we're really talking about processes that really require a deeper level of transformation in the clinic, on the clinic level. And the two models, really, when it comes down to it, there really are only two models that have prevailed over the last 15 to 20 years in terms of integrated care. And that's what's called the collaborative care model, or the COCM model. That's another sort of acronym that's often used for short, and the PCBH model. And it's important at the outset to say that each of these models are distinct. They are not in any sort of competition with one another because they have very distinct goals. They're going after very, very different problems and solving them. And in fact, the last slide that we're going to show you today shows you how you could actually be running both of these models effectively in a clinic, right? So in short, and hopefully throughout these sessions you have, you're going to get a more and more nuanced perspective of each of these. But in short, PCBH is trying to solve the access to generalized behavioral health support issue. So the issue that you have when a patient comes into your clinic and your provider tries to refer them out because they have depression, or they maybe just have some parenting issues or ADHD or any developmental issues, and they try to refer them out. But if you look at your statistics, only like 20% of those people ever make contact or successfully schedule an appointment with someone in your community. Or, as is happening a lot these days, there just isn't capacity in the community. You refer them out, but there's like a 3-month wait list for any behavioral health support. So PCBH is trying to solve that problem of creating more immediate, more ready access to behavioral intervention in the clinic same day. That's what PCBH is trying to solve. COCM is trying to solve a quality issue. So COCM, the folks behind COCM recognize that the chronic disease model back in the day, for those of you who are older like me, you probably remember the diabetes collaboratives of the late 90s, early 2000s. And that was based on the chronic disease model, which basically said, if you've got a really complicated condition, primary care doesn't handle that terribly well all the time. A lot of patients fall through the cracks of care. So a very tangible example of that is primary care providers will often underdose SSRIs, and they will often space visits out too far. So they might start someone on an SSRI for depression, and they might start them at a subtherapeutic dose just to be conservative. And then on top of that, they might have the patient come back in 6 weeks, when really we know we need to be checking in with that person in 2 weeks. So just like with diabetes, where you have a lot of kind of steps that you want to take to have good quality care, folks behind collaborative care model said, hey, we need to systematize the care of depression, and we need to embed measurement as part of that system and provide support to the primary care team in the form of a consulting psychiatrist and a care manager in order to effectively manage depression in the primary care environment, right? So it's trying to solve a quality issue, and it's particular to a condition, right? In this case, it's depression. Now, CLCM is being studied more and more, and there's some studies out there already on other conditions that CLCM could be effective for, PTSD, anxiety. But it's still focused on particular conditions. In most iterations, still across the country, it's still focused on depression, right? So you see how the models are very, very different, And again, at the end, we'll talk to you about how actually you could be running these models concurrently. Now, already, I hope your wheels are turning with respect to your clinics, because you might be comparing and contrasting what you're doing right now, or maybe even what you're envisioning if you're not even in that process, right? I want you to be thinking about, is what we're doing one of these models? Are these models serving as a framework for what we're doing? Or are we kind of inventing our own thing? Or we're trying to do what we think mental health in primary care looks like? And what I want to caution you is that we actually have a long history already of people trying to do their own thing with regard to integration. And in that 20-year history, the only two models that have come out as having any sort of systematic success and staying power are these two models, right? And the clinical pathways, including SBIRT, right? So if you're doing something different, or if you start hearing nuances that are quite different than what you're doing, that's one of the things we want you to pay attention to. Like, maybe you're going to have to really dig into these models and start reconfiguring your services in a way that matches what the evidence and what the standard of care, so to speak, in the community looks like. All right, so this gives you a little bit of a big overarching landscape view, global view of what these models and perspectives look like. All right, now let's look at the continuum here, because many of you, more than likely, well, as you were talking, you said that you may have had some mental health services. Some of you said you have co-located services and you're trying to move towards integration, right? And I probably don't need to convince you as to why that's helpful, but I want to give you some language and some concepts so that you can understand why it is that that's important. Why is it important to move from just co-location to really true integration of services? Well, what this sort of chart shows is that there is a bridge, there's a gap, I should say, not a bridge, there's a gap between the primary care system and the mental health system. So that's that left side of that triangle. That's what our current system is predicated on. It's predicated on two completely different, as you've heard before, siloed systems, right? You've got primary care, it's funded its own way, it runs its own way, it has its own traditions, its own structures, administratively and otherwise. And mental health has its own system and structure as well. So that's the problem we're trying to kind of solve, because we want to bridge that, because we realize it doesn't make any sense. People are whole people. Why are we developing two systems to care for the one person, right? We all know that that's the problem. So initially, and these things go back even to the 1970s, there were efforts to then say, well, let's just bring the two professions together, two systems, right? So we can bring mental health professionals into the primary care setting. So that's what we call pure physical co-location. You may have someone in the same building, you may have someone even down the hallway, or have an office of their own somewhere contiguous with your primary care floor. And what we have found time and time again is that physical co-location on its own does not solve the issue. Like it does not solve the access issue. It does not solve the integration issue, the coordination of care issue. Even if you have someone just down the hall in an office, that alone doesn't solve the problem. Why?
I was just gonna add, neither it's called a PCBH model, because a lot of people feel they have a PCH model just because they have a person who label in their job is a behavioral health consultant in the same space. So just because they have the label in their job description and they're in the same space, that doesn't mean that really you're running the model.
Right, and the reason why that is, as Martha well knows as a behavioral health consultant, is that if you have, like, let's say you're a mental health professional, you have your schedule is packed, right? Martha's schedule is packed with patients all day, and she's stuck in her office seeing those patients all day. And the physician is seeing patients in their office, and the physician sees a patient with a need, but because the physician can't go over and ask Martha to see that patient, but instead ends up having to maybe issue a referral or instruct the patient to go to the front desk and try to schedule a follow-up appointment with Martha. Essentially, the way that Martha's working doesn't match up at all with the way that the physician's working. And so the same issues that exist with the system now exist within your own system. You just happen to have a therapist on site who's seeing patients. And what often happens, ironically enough, is that that therapist will start seeing patients who are not even patients of the physician in the clinic. So they start seeing an entirely different panel of patients than the physician in the clinic, right? So physical co-location on its own doesn't solve anything. You've got to actually change the way that the professionals work with one another, right? And that's what the models do. Both COCM and PCBH change the way that the professionals work. So a consulting psychiatrist in COCM operates very differently than a specialty psychiatrist, right? A behavioral health consultant in PCBH has a schedule that allows them to see follow-ups, but spaced apart so that they're always available within about 15 minutes or so to see that warm handoff from the primary care provider at the point of care so that that patient doesn't have to make a follow-up appointment and miss out on seeing both the physician and the behavioral health consultant at the same time, right?
One of the things that we encounter a lot is that it's the mental shift that we have to do around the people that work in the clinic. If the providers, the people from the behavioral health, even support staff, when they've found themselves that they have someone in the mental health area, their mind is thinking, oh, that's the therapist of the clinic. So it's really changing the mindset, not just of the provider, but in general, the complete system, which that involves a lot of education and a lot of just reframing what is the role of a BHC and how the providers can use them in their daily work.
Absolutely. That's a fantastic point, Martha, because one of the things that Martha and I are often doing is not just educating and coaching the clinicians, but we also spend time with your front desk staff, with your medical assistants, with your nursing staff, with any other paraprofessionals, clinical pharmacists, dietitians, etc. Anybody who's part of that care team really has to have a good understanding of what it means as a team to care for the patient. And so when we look at truly integrated systems, regardless of model that they're running, the entire care team is what needs transformation, right? So one of the little tidbits here that you can take home with you is when we begin one of these consultation efforts with clinics to get a program going, or maybe even to make improvements, one of the things that we do is we bring together a meeting of these representatives from different parts of the care team, right? So it's helpful to be able to connect with the medical assistant, maybe the medical assistant lead, maybe the nursing lead, maybe a physician representative, etc. And if you have all those folks there, and then you start talking as a team and meeting regularly as a team through your change effort, then you have the buy-in and you're able to educate each member of the care team as to what you're trying to accomplish with regard to the model of care that you've chosen to deliver. Now, just to clarify before we move on, sometimes people leave and they get a little bit of offended because they feel like we're talking poorly about specialty mental health. And we definitely don't want to make it seem like we don't like specialty mental health providers. We love integrated care. We love primary care. That's where Martha and I work as our professional identity. But we're not saying that specialty mental health is not important or necessary. We're really just saying that the system needs to change so that we have both specialty mental health capacity and a primary care level of care as well. And the reason is because specialty mental health by nature is less efficient it's less flexible, and it's just designed to see less people. That's why specialty mental health doesn't do a good job with population health, because that's not the way that it's designed. Now, does that mean that it's not important? Absolutely not. We need specialty mental health capacity. And in fact, we believe that by introducing a primary care level of care in the system, we can help reduce the inefficiency in the specialty mental health sector by maybe taking on a bunch of those patients that would normally clog up the specialty mental health system with a more robust primary care system. So basically, for those of you who are system level people, what we're doing is really mirroring what happens in medicine. So in medicine, if you can think about what chaos it would be if we just had a specialty level of medical care, right? If you just had like dermatology, endocrine, oncology, et cetera, right? And that was the front door, right? You can imagine what chaos that might be, because the access would be really horrendous. If every time you had a skin issue, you had to go to see a dermatologist, you couldn't go to see your family medicine provider, right? That's kind of what exists right now with specialty mental health. We have just a bunch of specialists, and that's the access to care that we have. And so that's why we have the problem we have, because that level of intensity of care cannot meet the needs of the entire population. So we're introducing with these models a primary care level of care. But the challenge with that is that the training system, in other words, the folks that you want to hire to do this work, are not trained to do that. They are trained in the specialty model. So one of the themes that's going to come up time and time again in our conversations over these 12 months or so is going to be the need to effectively train the mental health workers in particular to really adopt a primary care mindset. Again, regardless of model, it really is a reconfiguration of professional identity for you to understand that you're working in a different part of the health system, that you're not operating as a specialist, you're operating as part of the primary care team. That's not something that I was taught as a psychologist in my training. It's not something that Martha was taught, other than the fact that she got her internship at Access. And so she was one of the lucky ones.
I have to add too that this is also like a professional preference. You might have found encounter people that are working that they just did not match with the primary care model. They just don't feel well working in that way, multitasking and fast paced, and that's okay. And as a leader, if you're one of the leaders in your program, you have to be able to recognize that they might be not a good match in some of the people that work with you, and it's okay to have those very honest conversations and say, well, maybe this is not the right place for you to work because you don't identify with that. So it's better to have those conversations than to force someone to do something that they just don't feel it goes with their professional preferences.
Yes, and that takes us to our second big take home. Remember, first take home was when you're trying to
Natalie,
should be together team. Yes.
There's a question in the chat that says, is it fair to say that you need both specialty mental health and integrated care? And I just want to pose that before you move on.
Yeah, I was actually just replying to that. I would say that yes, they're both necessarily, but one of the things that we realize is that when you have both in the same clinic, that can be very messy for even the people in the clinic, because they're really, a lot of people will be thinking they have this particular specialist and they will not use integrated care as they use. So it's better to not have it located in the same place. It's hard to have them both in the same place. That's why we have experience now. They're both necessarily, like we mentioned, we don't want to say that specialty is not needed and is not worth it. It is, but sometimes when they're in the same place located, it can be complicated. Or when they decide that the behavioral health consultant can do, for example, 3 days of a week as an integrated care and 2 days of a week as a specialty care. That can be, I think that just sets really early on for failure, because it's very confusing, not just for the providers, for patients, but also for the clinical staff.
Yeah, and I'll be even more direct in that and say that in all my years of consulting, I haven't seen a clinic effectively do that. I do both really well. People often point to, say, like Cherokee Health Systems, And Cherokee is maybe pretty much the main outlier. But the reason it's an outlier is because Cherokee started out as a community mental health center and shifted from being a CMHC to an FQHC. And since Cherokee came, that's the only system that's done that. So it's really, truly an outlier. And what we found when we're coaching clinicians, and yes, Jim, you can definitely jump in with questions. What we found when you're doing both roles as one clinician is that not only does it affect you and your clinical work, because you really have to think very differently as a specialist versus a primary care clinician, but it also, as Martha said, confuses the team because they don't know how to introduce you. Which part of you do they introduce? And do they introduce the primary care part? Do they introduce the specialty care part? How do they set the patient up for expectations with regard to what services they're going to get when they get connected with you? It just gets to be very, very tricky. And we just haven't seen anybody really successfully manage both roles at once. And as Martha pointed out, it can also be tricky just in general in the same space. These pictures are just there to pinpoint that, again, we're not saying one is better than the other. They're just different, right? I mean, we wouldn't get rid of art. Art is terribly inefficient. And it's not focused on efficiency. It's focused on beauty and it's focused on ethos and all of that. And we wouldn't get rid of art because it's inefficient, right? So we need specialty mental health care, but it's not very good at providing population-based health. It's good at providing fewer resources or lots of resources for few people. And so what we're saying is with these models, what they introduce is an efficiency. They're saying we need to touch more lives here. We need to mirror what primary care does in the community and in the health system. And in that way, it's much more flexible and efficient, much more kind of like a circuit board or computer, right? That's just the analogy here. It's not one better than the other. We actually just need both for the system to work effectively.
Can I just seek some kind of definitive clarity on this?
Sure.
I'm sorry, could you go back to that last slide? So if we have let's call it Clinic X that has a specialty behavioral health therapist that's in the clinic, that individual is taking referrals from, perhaps it's an access line, perhaps it's a central scheduling place. What I'm hearing you say is if you have that model that isn't necessarily working in a quote unquote PCBH model, that causes confusion, and you would really have, you would pause before you would say we're going to work towards an integrated model with that clinician that has their office that's seeing, I guess for lack of a better word, private patients or individual patients for outpatient psychotherapy.
Correct.
Okay.
Yeah.
All right.
Yeah.
That's helpful.
Yep. On top of the issue that, again, rejiggering mindset, and if you're again are at a system level, it's a little bit easier to see this. It's sort of like the difference between the mentality of an emergency medicine provider. My wife's an emergency medicine provider, as you know, and a internist, right? So an internist has in their mindset, like a thorough evaluation, big time workup, lots of labs, lots of this. And that's just part of their framework. That's the way they work. Emergency medicine is like, I'm just going to keep you alive, man. I'm going to do everything just to keep you alive. That's my job. That's it. Boom. That shift is the kind of shift difference between someone who's going to be effective in a primary care environment and someone who's just going to be a therapist in that environment. And so if you're trying to do both, especially both in the same person, your primary care providers are not even going to know how to introduce what it is the patient's going to get, right? Are they going to get a therapist who's just going to follow them over 20 sessions of weekly therapy? Or are they going to get someone on the spot who's going to coach them up over, 2 to 4 visits, and in a more ad hoc fashion that's primary care style, right? So that's the difference, and that's why it's really, we think, too complicated to really do both at the same time. Great question. All right. Promise you we're going to bring this all together here, but again, some language stuff here. And again, we'll go into more depth in future sessions on PCBH and nuances, COCM and nuances. If there's folks interested in ESPER, we can go into that as well. But there's some things that are tools that you may find helpful as you think about them. So if you focus in on the chart on the lower left of the screen, lower left, that first red row, you'll see there's something called a MEHAF score. And actually, there's 2 tools now that we use. MEHAF is one tool. It's a scale tool that you can use with your clinics, and we'll send you out with the slides links to those references so you have them, where you can actually rate where you are right now with integration, right? And this tool is pretty good at mirroring whether you are running one of the models, in which case you're gonna probably have a score between a 6 or a 10 on that scale, or whether you're running what we call a program. A program is just like something we invented at our clinic. It's not replicable. I'm not saying it's bad. It's just like it's unique to us, right? It's not something that's consistent and follows what these models have done at clinics across the country, right? So if you're running a program, your level of integration typically is between that 2 to 5 score range. And then the other tool that we will also send out that's actually a more updated tool is the practice information profile, the PIP. That's another tool. It's basically a questionnaire, and you can have different members of your team fill it out. That's what we usually do when we interact with clinics. Have them all fill it out. We get an average of those scores, and that becomes our baseline level of integration. So that's one of the activities that you can involve your teams in, just to say, here's where we are. We're at a level, we're at a 4 overall at our clinic, right? That's helpful, and say, well, what can we do to get to be more of a 5 or a 6 as we make changes over the course of this year? And the tool may direct you in those to those areas.
I want to highlight what you mentioned in the beginning, Naftali, for them to just keep thinking about where they feel they are, because it's very important that you are honest as to where your site is. Maybe you were believing for years that you were really doing PCBH, and right now what you're hearing, it's kind of making some noise. But it's important that you are honest to identify if it was just a program that you guys are running, or really, working on an integrated model.
And again, I don't want, this is not an opportunity to shame people, like, you should feel bad. No, it's really just about what Martha said, is just honesty. As long as you know where you are, you have a better chance of understanding what the pieces are you need to put into place to grow, right? Do we need to become more efficient with our payment pathways? Do we need to do some training with our clinicians because they're not really understanding the models? Do we need to work with our providers because they're not introducing services to our patients effectively? Or do we not have the right metrics in place to track what's happening? Those are the kind of questions that come up that are helpful in giving you specific to-dos for 2022 to say, this is the way we're going to improve our level of integration over the course of this year. A final little thing you'll hear us talk a lot about is called population penetration. And you see that's the lower row there on the screen. And that's a really important concept to think about, because remember that the goal of all of this is to have an impact on the population. So really to solve that specialty mental health access issue and that quality issue. So most of you probably are aware of the 4 quadrants, right? So the 4 quadrants is this 4-quadrant description of complexity, medical complexity and behavioral health complexity. And so you want to be thinking about, who are we trying to reach with our integrated care program, right? Are we trying to reach patients who have high medical complexity and high behavioral health complexity? Are we talking about low to moderate mental health complexity versus low medical complexity, et cetera? And so when you are running models, you should have in mind what your target populations are. Now, a robust PCBH program is going to be targeting all 4 of those quadrants to some degree, right? Even your most severe mental health cases, your BHC is going to be there standing alongside your physician, because we're never going to abandon your physician. That's the cardinal rule of PCBH. Don't ever abandon your care team. And so your physicians, if they're seeing a schizophrenic patient in clinic that day, even if that schizophrenic patient needs an ACT team, and that's really the main intervention, you're still going to be there standing alongside, working with the physician to make that happen, right? And to provide any support possible for that person, right? So that's an example of thinking through what the targets of your model are. So that's another key concept to think about. All right, so in the remaining minute or two here, I just want to show you visually. Don't feel like you have to read through this. This is very complicated, and you'll have this in your slide. But it gives you a sense of 14 weeks with a patient at a clinic that is fully transformed, and how this patient is cared for week to week across each of these models. In fact, in this exemplar, if you look at the chart at the top with the weeks, you have PCBH, you have COCM, and you have an SBIRT protocol running through all at the same time. And I'll just give you a quick overview of what happens here to inspire you that this is possible for you as you begin to look ahead at what you want your integrated care program to look like, right? So at that first contact, the patient comes in to see the PCP. And the chief complaints there are diabetes, out of control diabetes, and some chronic pain. But because you have COCM, you are screening, and they screen positive on the PHQ-2 for depression. And then the subsequent PHQ-9 was also positive on that visit. So the provider says, oh, I have a colleague here who works together with me, and they can come in and I'll see you right now. Would it be okay if they come in and work with you a little bit on maybe setting some goals for your depression? So the BHC is right there, comes right on in to see the patient on that warm handoff. And you see some of the items that they address. Motivational interviewing for some problem drinking, because I forgot to mention they also scored positive on the audit. And as they're talking, they figure out, oh, wait a second, underneath all this, there's some grief issues. And that's what triggered some of the drinking. That also led to some of the out of control blood sugars. And given the severity, the BHC powwows with the PCP and says, hey, we really think it's really important for this patient to get on some medication. And the PCP prescribes medication on that first visit, and they enroll that patient in the COCM program as well. So they get into the registry. Week 3 is the next point of follow-up, but this happens with the BHC. So this is a visit follow-up with the BHC. At that visit, you see some of the things that they review: medication adherence, some of the goals related to alcohol, and they review that skill that they worked on, the homework they worked on with the grief. And then the BHC doubles back with the PCP just verbally and in a written note, so that the PCP knows what's going on. Week 5 is a phone call check-in. The BHC, operating as a care manager there, checks in on med adherence, checks in on the goals, reminds them of their visit coming up in the following week. And then they come back in week 6 to see the provider and the BHC together at that week 6 visit. And you see some of the goals that they work on at that time, both across diabetes and the behavioral goals. Week 8 is another phone consult from the BHC operating as a care manager. But then at week 8, you also have the consulting psychiatrist performing a chart review and discusses with the BHC some modifications to the SSRI. Maybe they up the dose, maybe they augment at week 8. based on what they're seeing with the PHQ-9 scores, right? So the consulting psychiatrist hasn't seen the patient. They just comment on the patient from afar and provide guidance to the prescribing provider, the primary care provider. Week 10 through 12, you see there that there is yet another PCP visit there at week 10. At week 12, you have another phone consult. And then finally at week 14, a follow-up visit with the BHC to check in on progress. So you see the interweaving here of all the visit types, all the contact types, the roles of each of the professionals, all operating in a seamless fashion, treating the patient as one patient. So you'll have all these slides. You can look at some of the particulars, some of the details and all of that, but this is the vision that we want to give you, that if you're able to run one of these programs or multiple of these programs at once, you really can have a significant impact on continuity of care, quality of care, and you don't have to refer the patient out to a specialty mental health provider to get that done. Plus, you really support your primary care providers and make them much more effective. You notice that in 14 weeks, you have 3 visits from that primary care provider. They don't have to share the burden of caring for this person on their own. All right. I know I pushed it all the way to the end. I apologize for that. There's a lot of information. I want to thank you. It's 3 o'clock. We're happy to stay a few minutes if there's some folks who want to ask some questions and talk with us. We can stay for a few minutes, but for those of you who do need to pop off, please feel free to pop off. We will see you next month. And please be in contact with the folks at WCHQ for any of those one-on-one sessions you want to have with us.
I think you scared them when you said 3 because it's 2 for us.
Oh, sorry.
They're like
Great
3.
first presentation, you guys.
Thank you.
Yeah.
Really good. Thanks, guys.
Thank you. We'll see you next month.
Bye.
All right. Looks like people are popping off.
All right, you guys, it was a terrific first presentation. Thank you. I'm really excited. We had 6 health systems on today. One person who is joining is out on medical leave this month and she'll be back next month. So we'll be at 7. And then the 8th is the one that has the conflict right now. But I did send you guys a list of everybody who was there and who their health system was. So you can start to get to know the names and health systems. You have that in your email right now.
Super helpful, Jen. Thank you. I saw that, and I'm gonna send the slides shortly this afternoon.
Perfect. I'll probably send them out tomorrow, but thank you so much. Yep. You guys are fantastic. I can't wait for the next session. You guys are great. Thank you.
Bye, Jen.
Good afternoon.